let's welcome our next speaker, Dr. Kerry Jewell, who is a nuclear medicine physician and a PhD candidate from the Cancer Imaging and ProsTIC team. Just a bit of a change of tack of topic. She will focus on post-therapy imaging, and do we really need it?
Yes, but I'm an imaging specialist, so I'll go on in a little bit more detail with some nuance to that answer. I am in week 2 of my PhD with Michael and Arun as my supervisors, but last year I was the therapy fellow at Peter MacCallum, and so I had a really good opportunity to spend a lot of time with patients in our high volume centre to get a bit of a sense of how post-therapy imaging influenced their journey. So these are some of the themes that I was thinking about last year when I was thinking about our patients. Generally, when we see patients in clinic and we're giving them updates, there's 3 parameters I'm thinking about: their clinical state, their biochemical picture, so what their PSA is doing, and then fortunately we at Peter Mac have the ability to look at their post-therapy imaging as well. So the day after they've received loop PSMA, they come and have some post-therapy imaging and then see us in clinic. So I've broken this down into 3 sections, so reasons why I think the post-therapy imaging is good. So I think it helps with our management decisions. So in this example here, we can see a 91-year-old patient who used to take the tram to come down and see us. And each time he would see me in clinic, he would say, "Do I actually need to come back the next time? I really like seeing you, but it's a long tram trip." And so we would show him these pictures and he would get a sense of how he was going with therapy. We're also really fortunate to be able to print out a paper copy so he could put it on his fridge and show his grandkids. So we had a really clear indication there of some good that we were doing. I like this case too, so I'm going to show you a super response here where we can see from a clinical and PSA perspective this patient was doing well, and that was confirmed with the imaging that we did too. So we were able to stop after 2 cycles here with no targetable disease. And I think that is important when we're thinking about targetable disease. So in this case, this is another patient who received 2 cycles, but we can see quite clearly after the 2nd cycle that there are many more avid lesions present, and together with PSA and clinical findings we were able to change this patient over to cabazitaxel, and the imaging was really reassuring to help us make that definitive decision. So moving on, in the interest of time, I think the second point I'd like to talk about is the incidental findings that we get. We have the benefit of seeing patients every 6 weeks. We can look at their low-dose CT in particular, and that can lead to some management changes. So in the first example, this is a patient who had bilateral pleural effusions. This was on their cycle 3 post-therapy imaging. In this case, we didn't actually have post-therapy imaging for their 2nd cycle. They were unable to come in, and the effusions developed between cycle 1 and cycle 3. We were kicking ourselves, it would have been really good to have one after cycle 2, but then we remembered that we're physicians and can auscultate as well. So, but this helps, it does help. In this case, we picked up a bowel obstruction. Now this patient, it's a little bit of a challenge to get him into hospital, so when we were able to show him these pictures, he reluctantly agreed to an inpatient admission where this bowel obstruction was managed conservatively, but it gave us the opportunity too to explore his analgesia, and it turned out that he was using long-acting oxycodone as a PRN sort of every hour or so, and so we're able to optimise his analgesia as well, which is really helpful. And now this last image is a little bit of a teaser for the multidisciplinary meeting that's happening tomorrow. I hear that it's going to be really good, just word on the street. So this is a teaser for one of the cases that we're going to be looking at, and really this is to show that our post-therapy imaging too, we can have a look at lines that are in, and particularly when patients are having urinary interventions, just keeping an eye on how they're going. So I won't spoil that case for tomorrow. And then thirdly, putting it all together and leading on from Ting's talk as well, really it comes back to the patient. And so when I see these patients in clinic, I'm thinking about what the image can do to them for a psychological point of view. So numbers and how they're feeling are really great, but I think for a lot of our patients, having that visual affirmation of what is happening to them can be really, really helpful. I was trying to think of a good example for the physical impact post-therapy imaging can have, and actually the only thing I could really think of is just some of our patients, when they've been on loop PSMA for a little while, start feeling really good. So it's also great to be able to put up the images as a reason why they shouldn't get back up the ladder so quickly. And then from a logistical point of view, we had a great example of this in January, where we were already doing some forward planning for the third week of February to make sure that our patients coming in from the country had accommodation, because they were competing with Swifties for those hotel rooms. So again, making some proactive decisions with post-therapy imaging, very, very helpful. So the title of this presentation was Post-Therapy Imaging, Do We Need It? But I actually think it's Do They Need It? And so all of those factors I was thinking about and bubbles at the start of the talk, I've put them up here. And I really think, from my experience in our clinic last year, that the post-therapy imaging on average is beneficial. Of course, there are potential disadvantages. It takes quite a lot of effort to schedule. When we've had 12 treatments the day before, the technologists at our centre do an amazing job scheduling everyone in and getting everyone through their scans. There's the cost, financial, yes, but also to the patients. They have to come in for a second day. It can be uncomfortable on the scanning table. So those are things that we have to weigh up. And as we heard earlier, there are some patients who we may not scan for various reasons. But again, I think on balance, thinking about the patient and putting them at the centre of things, I think we come out on top with the post-therapy imaging. And then my last slide, this is a quote that appears on all the desktops at Peter MacCallum, and I think this is really what it comes down to, that if there is something that we can do, even if it's only a little bit, to improve the experience of the patient, we should be doing it. Thank you very much.